Good morning and welcome to another edition of Facebook Focus live here at St. Mary's Hospital. My name is Hasnain Kermali. I'm the Chief Medical Officer here at St. Mary's in Waterbury, Connecticut. And each month we like to provide you with a little bit of exposure to the various expert services and providers we have for the community and share with you some of their insights on our programs here. So this month, I'm truly excited, like every month, because we've got together with me today Dr. Alexander Palesty, and we're focusing on the Department of Surgery, who's truly not only teaching and mentoring from a surgical program perspective of residency. We've got a very robust service for the community in terms of the types of surgeries we're able to offer here. But what I love is the high quality patient safety centered care that's provided here. And so Dr. Palesty is joining us, a number of different hats that Dr. Palesty wears, along with being a surgeon here. He's the program director for our surgical residency program. He is the director of the simulation lab that we have here at St. Mary's Hospital. And he's also currently serving as our interim chair of surgery for the Department of Surgery. So thank you very much, Dr. Palesty, for joining us.
And I'm also the father of 3 young boys at home, which takes up an inordinate amount of time as well.
Well, that's very, very important, because
my other job.
Your history here at St. Mary's is great. So tell us a little bit of your personal side.
Sure.
Because your story is not just about what you do here at the hospital, and it's not simply surgeon at St. Mary's along the years.
Sure. My life here at St. Mary's started when I was a child, because my dad was a head and neck surgeon here. And so my introduction to medicine, to the hospital, was playing with my Matchbox cars on the floor outside of medical records while my dad would complete his notes, and then rounding with him on the floors in order to spend time with him because he was that busy. And then in my teens, I was hired here to work as an orderly in the operating room, and I think that's where my love of surgery came from. It wasn't the science of surgery, it was sort of the social aspect of surgery that attracted me to it. And frankly, I didn't realize my connection to medicine until I was through college. I think I denied it, and I studied everything from architecture. I did an architecture internship. I did archaeology. I mean, I really kind of ran the gamut. And, you know, when push came to shove after I finished school and was wondering what I should do with myself, I was still working here as an orderly in the summers and realized that this was really what I wanted to do. So I went back, I covered all the things that I needed to in terms of studying sciences for my application process, and wound up in medical school. When I finished medical school, I actually came back here and did my residency here, and spent 6 years with Dr. Dudrick, who was my mentor. And for those of you who don't know him, he was the person who invented feeding by vein for people who could no longer eat by mouth. And so very integral to the development of surgical nutrition, and spent a lot of time with him, doing a lot of research with him, and really getting into the academic element of surgery. And once I finished residency here, I went on to Roswell Park up in Buffalo, did a fellowship or further studies in cancer surgery, and then came back here in 2005 to assume my role as one of the surgeons on staff here. And when I came back, I wanted to continue to give to the community. That's one of the reasons why I came back, and really wanted to give back to the residency. So I became the associate program director, and then ultimately program director, going on almost 12 years ago. And so I've been involved with teaching since then, and then recently had the honor of accepting the role as the interim chairman while we search for a permanent chair.
So that's your clinical side. What do you like to do in your off time?
My off time is consumed with my kids now. You know, I I really enjoy going home and really being with them and just sort of engendering the joy of their joy and participating with them. Outside of that, we live on a beautiful piece of property. I have about 100 apple trees, which I cultivate, and spend a lot of time outside doing things of that nature. And I love to travel, and so as a family, we try and travel together as much as we can.
Wonderful, wonderful. Now, you had started talking about the residency program. I think it's an area that many people have a familiarity with, but not truly good insight. So let's talk a little bit about the surgical program. You said you're the program director. What is the program? What does it do? And how do we develop surgeons through our program here at St. Mary's?
Sure. So, as program director, basically my responsibility is to take students who've finished medical school, who are interested in surgery, and develop them both clinically and technically into surgeons, people who can think through the problems, address the problems, and then fix them, and then take care of the patients post-operatively. And that's a 6-year process in our program, so it's a commitment from all sides. And so it's really satisfying because you have the opportunity to watch these young minds mature and develop into a finished product that, is so satisfying and surprising at the end of the day. They come in as kids who have never really had the opportunity to work in an environment that's so close-knit. Many of them have absolutely no work experience, so it's a little bit of social training.
Sure.
And there's some cultural training. We have residents from all over the world, and then there are the clinical and technical aspects of it as well. And so that's essentially what it engenders. We also do a lot of clinical research here, as well as we have our residents spend a year in a research laboratory up at UConn, where they're currently doing a lot of investigation into cardiovascular effects of surgery, and then into wound healing as well.
So when we talk about patients as they come through the hospital, how much interaction do they have with the residents from a surgical perspective?
Sure. The residents are the first line. They're the first people on the surgical team that a patient will meet. Most of them know the majority of our residents by the time they've left, and then obviously they see us during their stay. But the faces that they become most familiar with are the residents. And that's why it's really so important to teach them how to interact, how to explain the process appropriately to patients, and really educate patients so that they understand their disease process outside of just saying, okay, doc, whatever you want to do.
Right. And so your experience prior to coming into medicine, do you feel that that was a positive thing for you overall, in terms of the breadth that you had before going to medicine? You did talk about some students, and many times today students on their pathway, they go from high school to college to medical school, not really taking time necessarily between as they move through a very directed process. When you reflect back, do you see that time that you spent sort of, dare I say, exploring other areas as fruitful for who you are today?
It's a great question, and it's a question that I always talk with my residents about, and it's actually become part of our investigation into people who are looking into the program. I think it's of utmost importance that people have a wide breadth of life experience before they enter a surgical residency. For myself, I went to a foreign medical school. I lived in Grenada for 3 years. I lived in England for a while. I lived in Germany for a while. And so I think that gives you the ability to speak with people from other cultures, to understand them, to listen, and gives you the ability to really learn how to engender trust. I think, you know, my students, when they come into the office, they always leave laughing because I spend probably 10 minutes talking about their medical problems and 20 minutes just talking about them. Person comes in with the tattoo and I'll just say, tell me the story. Because it's a window, it creates a commonality and a trust. And so they talk about themselves and they'll tell me the story behind their tattoos, or if somebody's Jamaican because, you know, Grenada's so close to Jamaica, the culture is the same. And so speaking toward whatever their food is, or things that just create this innate sense of comfort and trust. And I think that comes from having a non-medical education.
And again, it's that focus that we want to continue to develop here at St. Mary's, putting the patient first. So it's not simply about the surgical problem. It's not, let's get you to the OR. Let's talk about you as a person. Let's get you know you, because I think that's greatly impactful on the quality of care that they get, because there's that trust, that degree of relationship or relatability, so that now you can actually appreciate some of the nuances that will actually help them on their healthcare journey, to understand some of the things that are going outside of necessarily these four very controlled walls of the hospital, compared to what they're going to be dealing with outside of the hospital.
Absolutely, and I think it also allows you, once you get to the crux of the problem and you start asking important and sometimes uncomfortable questions to the patient, they're far more willing to give you the whole story once you've established that sort of relationship. And I think that's really one of the focuses that we have in our residency, is learning how to establish those relationships. I think what I've found is, all too often in the first 2 years that they're here, you know, they walk into a room and they're just all about getting the patient to the operating room, taking care of the problem, dotting the I's, crossing the T's, and they forget that this is a personality laying in the bed. This is somebody who has a family, who has a history, who does things that aren't necessarily related to what they're here for now. And I think it's important to remember that. So
part of the residency means getting exposure to a breadth of different procedures to some degree. And we do have quite the variety of surgeons, and you've known this in your role here for the number of years, but definitely now as the interim chair of surgery. Tell us about the different services that we're able to offer, and how they combine and truly wrap around the patient along the way.
I think, you know, this is one of the advantages of being in a smaller hospital, is that, you know, all of the service line here know one another and can interact fairly comfortably and frequently with one another. And so it allows us the ability to pick up the phone and talk to one of your colleagues when, you know, there's an issue. And so I think we have some fantastic services here, and we have great relationships. You know, we see about 900 trauma patients here a year. We have a very robust trauma service. We have an ICU critical care trauma-trained physician who takes care of the sickest patients and guides us through taking care of trauma patients. We have a neurosurgical service that is on the front line, is doing some really neat stuff with some cool technology at this point. Orthopedics is very robust, and these all work together within the trauma service. We're constantly in contact with one another about how to manage patients, how do we take care of them, because ultimately it's the general surgeons who are the bottom line in terms of caring for the entire patient, and then these different service lines come in and give their opinion, and it's up to us to sort of bring those services together. We have a very robust urology team. We've hired another sort of urologic oncologist or cancer surgeon on board who's going to be starting soon. We have a very strong bariatrics program. And I think tying that all together is our interest in constantly being at the forefront with technology. St. Mary's was one of the first hospitals in Connecticut to use robotics. with our gynecological service line. And we started with one robot, and it was really predominantly urology and gynecology who utilized the technology for the first 4 or 5 years. And then the general surgeons got on board and said, you know what, why aren't we taking advantage of this fantastic technology? Yeah. So as a group of general surgeons, we were the first to really get involved with using the robotic platform for what we do. And that's blossomed into us probably being one of the premier robotics programs in the state, having 3 robotic robots within our system now,
yeah, and
having other service lines start to use it. And so our gynecologic teams use it. So I think it's a fantastic small hospital that kind of goes under the radar. And having been a proctor now for robotics and having been to other places to see how other people operate, I can say with no bias that we do have a very talented group of surgeons here.
It's remarkable to see, again, the communication that sometimes goes on in a trauma situation, or even for a non-traumatic case. The connection that you all have between each other is phenomenal. It truly is. When you're able to call up somebody, and even less than a call, because you meet them in the hallway, you know them by first name, you know who's around just because of the day of the week, and then immediately being able to hand off patients directly from one physician to the next in terms of problem management, and then moving things together to help the patient and keeping that patient flowing in the multitude of problems that can occur. It truly is beautiful to see, but not only from a small community hospital, but the quality of care. You talked about the robot being one of those new technologies that were brought on board a while ago, incorporating that across the surgeons, and then expanding our capabilities. Now having 3 robots here at the hospital allows our patients that quicker healing, that less time in the hospital, getting back on their feet, along with the technical expertise that's needed for the robot.
And just to dovetail into our conversation earlier, we're now training young surgeons who are completely adept at using that technology by the time they finish.
Right.
And having had many of them finish here and go on into further training in minimally invasive surgery or other areas, thoracic surgery, where it's kind of new to use the robots. These kids are going out there and are completely independent in the fellowships where they're supposed to be learning, but they're actually teaching some of their instructors the nuances of using a robot because they're so familiar with it, because we do so much here as compared to other places.
Yeah. And then I think this is interesting, is it's not simply we're doing it on patients. Let's talk about the simulation lab, because I think that's another area of importance in terms of our program training and development of the residents. Tell us a little bit about the simulation lab, what we're able to provide here for our students, for our residents.
Sure. I think the simulation lab is where it all starts. We try and have our trainees use the sim lab before oftentimes going live on a patient. And the sim lab was a vision that I had with Dr. Dudrick years ago. And we created a fund between the 2 of us to help get it started, and basically created a room that has all types of different equipment that we can use to train our residents. And not only that, we've now incorporated the medical residents into it, but we have a simulation mannequin where we can simulate cardiac arrest, we can simulate trauma scenarios. It's Wi-Fi enabled so that the vital signs will come up. It actually has a heartbeat. You can put a tube in to help it breathe. You can put IVs in it. You can do all the things that you need to do like you would do in real life on a real patient.
Yeah.
And we also have a room with a one-way mirror that the instructors can be in, so that the trainees don't necessarily have direct vision of the person who's quote-unquote grading them. And then afterwards we deconstruct it and we talk. There's also another room where the people who aren't involved in the training process can watch what's going on. And then afterwards we debrief. For medical students and some of the younger residents, we have pads which they learn to actually make an incision and sew it closed. There's a robotic trainer within there. They have laparoscopic training skills. We also need to learn how to do colonoscopies and bronchoscopies and upper gastrointestinal procedures, for which we have a trainer for that. So we're very active, and I think we were sort of ahead of the game on that. Now it's become a requirement for training programs to have simulations labs, and ours has been in the mix for at least 10 years, if not longer.
It truly is remarkable, again, what St. Mary's is able to offer to the patient, to the trainees that are going through their training here under our roof. You mentioned it was flying under the radar. I'm always of the opinion that we need to make it fly over the radar, make sure that it's well clarified, because it's important for patients who have choice and for trainees who have choice, that they understand that we can provide that kind of care, and you don't have to go outside of your backyard.
For sure. And I think ultimately having a simulation lab, what that translates into is better patient safety,
right?
Because people aren't an experiment. These people have already worked and done these procedures, and obviously all of these things, even the procedures live, are under the auspices of a surgeon. They're not doing it alone, but the fact is they come in having a comfort level that they wouldn't have otherwise. And so I think from a patient safety perspective, it makes a massive difference, especially practicing trauma scenes or scenes for cardiac arrest that happen on the floor where everybody's involved. It allows for better communication. It teaches people the lines of communication, the hierarchy in terms of how these intense emergency situations should occur.
Right.
And so it becomes natural when it actually happens.
Yeah. Let's shift gears a little bit. You also help. There's a lot of you alsos, which is fantastic. You help in the wound center here as well. Tell us a little bit about the wound center.
Sure.
And we've had Dr. Jacoby, of course, here to discuss that, but it's also an area where you help out.
Sure. My interest in wound care stemmed from my experience with cancer patients and cachexia, and because those patients have very poor wound healing and have no excess tissue, they oftentimes develop wounds. And so I became interested in wound healing through that and through my surgical nutrition training with Dr. Dudrick. And when I originally came back, the Wound Care Center opened back in 2005. So I became a part of it because of my interest there. And really what it's done, it has allowed patients in the community to have access to experts who can help their wounds heal more quickly, make them more comfortable, and really take care of some very complex wounds.
Yeah.
We have the good fortune of having 2 hyperbaric chambers in the Wound Healing Center, which allow patients to essentially be submerged to a pressure of about 33 atmospheres, which is about 30 feet underwater.
Yeah.
And what that does is it drives oxygen into the wound to help it heal faster.
Sure.
And so that's a daily process for them for anywhere from 30 days up to 3 months to help these diabetic patients heal faster, to help avoid amputation. And there are a number of other things that we do there as well. And so the Wound Care Center is run by Dr. Jacoby, who's an emergency room doctor, myself, another surgeon, Dr. Zarif, and Dr. Kakowski, who's another emergency room doctor as well. And again, we all communicate because we see each other all the time, so if there's a wound that those guys aren't comfortable dealing with because it requires a little bit more hands-on care, they'll hand them over to us.
It's remarkable, again, the connectivity that's present here, that you yourself have helped develop along the ways and are intimately aware of. And that's what I want to say thank you for what you're continuing to do along the way in terms of moving this along. One thing we definitely want to make sure we take advantage of while you're here is your clinical expertise. You've trained in oncology, surgical oncology as well. Give us a little bit of an insight on that piece of the puzzle.
I think Oftentimes the general public doesn't realize that cancer care is a little bit of a different specialty than general surgeon. And there are nuances to taking care of the cancer patient that differ from the way a general surgeon would take care of a cancer patient. There's also a multimodality approach to cancer care, which involves not just the general surgeon, but their medical doctor,
Sure.
their oncologist, their radiation oncologist oftentimes, physical therapy, occupational therapy, radiology, and so there's a lot more to taking care of a cancer patient than just seeing them in the office individually.
Yeah.
Similarly to bariatrics, which we do a really good job at as well, where it's not just the surgery, it's the follow-up with nutritional care, a nutritionist,
Right.
making sure that they're meeting their goals. So with cancer care, we have very robust multimodality conferences where we discuss patients with all of those aforementioned people,
Yep.
so that we can provide patients with care from every aspect, not just cutting the tumor out. And I think that's important, and I think it's important that the patients understand that it's several different people who are constantly in communication in order to augment their care to their best ability.
Yeah, and that kind of wraparound service for the patient, keeping them in the center, is what allows them to get through that journey in actually a very streamlined fashion. We take that work away from them of having to reach out to everyone, and you're able to put it all together for them so that they have to deal with everything else along the way in that journey. But at least from the clinical perspective, all the teams are connected and holding their hands as they go through that pathway.
Yeah, and I think it takes away from the worry from the patient. They don't
Right.
have to worry about making appointments or who do I go to next or how does it work. We take care of that for them so they can focus on their disease process and getting better and hopefully healing primarily mentally and then physically as well.
Yeah. Again, thank you very much. But before we conclude, one thing we always ask our presenters is to offer one last pearl or nugget to our audience for their continued benefit.
Sure. I think the nugget that I would offer is that patients and people need to be aware of the improvements in technology and medicine as a whole. And before accepting sort of your quote-unquote fate or diagnosis, I think be aware of what's available and ask your practitioner. I think St. Mary's has been really good at being at the forefront of trying to incorporate new modalities of care.
Yeah.
And I think people should really be aware of and investigate what's there for them to choose from. And I think we're fortunate that we have a lot to offer, and we can offer patients really some of the most upfront and innovative care that's out there. And so I don't think you always need to go to a tertiary center to get that kind of care. And I think what makes us special is we do have that personalized care. You're not just a number in a big institution. You're a face and a name, and I think that's super important.
Super important. Again, thank you very much, Dr. Palesty, and thank you all for joining us. Look
Thank you.
forward to seeing you all next time.